lack of comfort can affect your other disease processes. And we'll learn more about that. I hope you guys had a chance to go over your SLOs and also your reading so that you could participate in the class today. And of course, your SLOs guide your patient care, and it also guides this elective. To 9 hours of sleep, they consider that sleep loss, but everybody has a different amount of time they need to sleep. I, for example, only sleep 5 to 6 hours. If I sleep more than that, I'm exhausted. But they want you to, they say 7 to 9 hours is the appropriate amount of sleep in order for you to function properly, right? And sleep deprivation is a common problem amongst all people. And I posted a link to the Healthy People 2020 on the Canvas site, and sleep has now become a Healthy 2020 initiative. It's now a social determinant of health. 10 years ago, it was not. So that's how important sleep has become, because if you don't get enough, it affects your ability to fight off infections. It supports your metabolism of sugar to prevent diabetes. It's necessary to perform well in school and also to work effectively and safely. And that's very important because you guys are going to be nurses. So you want to be effective and safe practitioners, right? So make sure you're getting enough sleep. And for my night nurses, I don't know what to tell you. Make sure you sleep during the daytime whenever you can. It's because adequate sleep is essential for maintaining health and renewing energy. Also, drowsy driving is equivalent to drunk driving. So it's important that we get that sleep. This is just a diagram of the sleep cycle. It's here for you. Read it at your leisure. And it's in your text as well. So we discussed how much sleep does the average adult need. Of course, it's 7 to 9 hours. So what are some causes of poor sleep patterns? What can cause some poor sleep patterns in individuals?
Anxiety.
Anxiety, definitely. Emotional stress.
Depression.
Depression.
Insomnia.
Caffeine.
Caffeine, definitely. Smoking, caffeine.
Certain
diet,
medications.
Medications, yes. Some medications cause nightmares. So all those factors affect sleep. And what are some consequences of not getting enough sleep?
Irritability.
Yep, grouchiness, irritability. And probably inability to function throughout the day. You're not as quick. You can't think as well. You're probably confused. So all of
Can't you
those
have
are
like hallucinations?
hallucinations. All the consequences of not getting enough sleep. Poor wound healing. Affects your heart. And this is a little chart that shows how sleep deprivation actually affects your body. And y'all don't have this. I'll post this PowerPoint, but they're essentially the same. I just threw in a couple of graphs, but it affects your appetite, your memory, your libido, your activity. So it affects a lot of things, and it weakens your immune system, puts pressure on your heart, causes heart disease, high blood pressure. So it's very important that we all get enough sleep. I know I don't. I'll be the first to admit I don't get any sleep. None. I probably got 3 hours last night, just so you know. And so we're going to go over a few sleep disorders. And again, this is inability to fall asleep, inability to stay asleep, and also disruptions of sleep. We're going to do insomnia. We're going to touch on obstructive sleep apnea because Dr. Yini will go into that more with her lecture, narcolepsy and restless leg syndrome. Again, there's a little plug, page number. So insomnia. This is the most common sleep disorder, and a person has trouble falling asleep or staying asleep. It could be primary or secondary, meaning primary meaning they don't have any other medical conditions that affects their sleep. So insomnia is all that they have. They just have insomnia. Insomnia is diagnosed when someone has like 3 months of inability to fall asleep at night. So it'll have to be 3 months. And if it's secondary, it means you have a medical problem, maybe CHF, diabetes, rheumatoid arthritis that causes chronic pain, and you can't sleep because of that. So there's primary and there's secondary. So we already discussed some causes of insomnia or inability to sleep. There's emotional causes, there are physical causes, and also environmental factors. We didn't discuss the environmental factors. What are some environmental factors that could cause insomnia?
Noise.
Noise, lights. Yeah, so if patients in a hospital, those are some environmental factors. If it's too cold or if it's too hot, noise, light. If hearing the nurses talk about their weekend, that'll keep anybody up. So they might want to just shut their doors. We'll talk more about that. And disruption of routine and pain, they all can cause insomnia. And so treatments, all the treatments for all of these disorders are going to be essentially the same. We want to improve their sleep hygiene, stimulus control, like lower the lights, give them covers, make sure it's warm or whatever they need, coolness, warmness. So controlling those environmental factors, teaching some relaxation techniques, some exercise, and some cognitive behavioral therapy, which we'll get more into. And another disorder, the one Dr. Yini will go more in depth with, is your obstructive sleep apnea. And this is caused by partial or complete obstruction, and the patient will have like apneic episodes. And usually this is recognized by their significant other, and they'll kind of say, you haven't been breathing throughout the night, because the patient may not even be aware that they're not breathing. And risk factors for obstructive sleep apnea, one of the main ones is obesity. And one of the primary signs is snoring. And the therapist for this is lose weight. They may have to go on weight reduction, avoid alcohol, and you'll see patients with them CPAP and BiPAP machines on, or they may have surgery to remove the obstruction. And so there's some teaching on page 108 about the CPAP and the BiPAP. And when should they have the CPAP or BiPAP machine on? Is it at night, anytime they want?
Anytime they go to
When they're
sleep.
sleeping.
Anytime they're sleeping. If it's in the daytime, they have it on. If it's at night, they'll have it on. Correct. If they feel like I'm breezing through this, no worries. I'll let you know what you need to know. All right. All right, another disorder is narcolepsy, and this characterized by that daytime drowsiness. These are the patients that you could be talking to them, having a whole conversation, and they just nod off in their sleep. And they have dreamlike hallucinations, and they think it's caused by the nervous system disorder, where the brain can't regulate sleep-wake cycles. And again, here we go again, medication, good sleep hygiene, counseling, and support groups, all the same. And lastly, we're going to discuss restless leg syndrome. That's when your legs just twitches and it's an unpleasant sensation. I actually have this from time to time, and it's very uncomfortable, and it does keep you awake, and it feels like nothing helps. But yeah, so some things they want you to try is gentle stretching, massage therapy, And here we go with good sleep hygiene. So the commonality in all of this is people aren't getting sleep. They're not getting quality sleep. They can't fall asleep. They can't stay to sleep. So these are some manifestations you may see, and you kind of discuss some of them. You get that sleeplessness, lack of concentration, daytime drowsiness, affects your ability to drive. And again, it leads to other healthcare related problems such as diabetes, heart problems, high blood pressure, and disrupted APLs. So some collaborative care. The only real diagnostic test they have is sleep studies. And is there any particular preparation that's needed by the patient to have a sleep study?
Don't drink any caffeine.
Oh, I didn't think about that one. That's a good one. Yeah. Don't drink caffeine. Other than that, there's no real prep. Just come ready to sleep, and then the text, and they'll do the rest. There's no real prep though. And so pharmacotherapy, and there's a list again. I referenced the list for you, the page number. But they'll get sedative, hypnotics, anxiolytics, benzos, and barbiturates. So when we give a medication, any medication to any patient, what must we know? What must we be able to tell the patient?
Like when to take it.
Interactions and side.
Yeah, we need to tell them side effects, nursing considerations. So what are some side effects of taking these medications and or some nursing considerations? What do you think?
Driving, or, you know, see how it affects you. Take it like some of them you only take right before you go to bed. You know, could cause irritability in some people.
Yep.
And you don't want to take other CNS depressants with them.
Okay, you don't want to drink alcohol with it. You don't want to take any other CNS depressants. And so you have to know the half-life of the medication. So half-life means it works quickly, but it leaves your system quickly too. So people having trouble falling asleep might need the medication with a short half-life, meaning they need just enough to put them to sleep. And people who have trouble staying asleep need medication with longer half-lives, right? And then we talk about that these medications have a propensity to be addictive. So before we introduce pharmacotherapy, we need to try everything else, the cognitive behavioral therapies. We need to try sleep hygiene, because these medicines do have a propensity to be addicted. And also over time, the tolerance just builds. They'll need more of the medication to get the same effect. So we want to use this as the last resort. And only for a short amount of time. So if we're using it for a short amount of time, how do we get these patients off of this medication?
Wean them off.
We have to wean them off. We have to taper them off, just like we have to taper off of prednisone. We have to taper them off these medications to prevent withdrawal, right? And before giving these classes of medications, you have to make sure that you are doing a good patient history, because it's contraindicated in patients with cardiac, respiratory, kidney, and liver disease, and also pregnancy. It's contraindicated with these patients. And what about giving these medications to the elderly? What we need to be watching for?
Kidney and liver function.
Yeah. Kidney and liver function.
Like dizziness?
Dizziness. And what's the issue with them being dizzy?
Could fall.
They can fall. So that's it. As simple as that. So the side effects are amplified in the older persons because they can't clear this medicine as quickly as younger people, right? So dizziness, hallucinations, hypotension, and vertigo. So we have to provide for safety. And how are we doing that? If they're in a hospital, how are we providing for their safety?
Lowest bed, side
Side alarm.
rails, the call light within reach.
All those basic safety issues, making sure that there's light to the bathroom, or even giving them a urinal or even a bedside commode so they don't have to walk, right? Call light and reach. those basic things we need to remember to do because it's amplified, side effects are amplified with these patients. So how about melatonin? Y'all see melatonin given a lot lately, right? Given a lot for sleep. So can we recommend that the patients take melatonin if you're working in a clinic, the ER, and patients say, I can't sleep at night? What do you recommend? Could you recommend that they get themselves some melatonin? It's over the counter.
No,
Depends on what they're taking in addition to that.
Yeah, so you shouldn't because you don't have time to see what they're taking in addition to that. So you refer them to their doctor. Even if you say, talk to your doctor about melatonin, that's okay to do that, but we can't go say, go buy yourself some melatonin from over the counter. That's gonna help you sleep. No, we don't want to do that. So medications, last resort. And there's a list of them in your text. So non-pharmacological therapy, this is where we want to start. So what are some cognitive behavioral therapy that we could recommend for patients who are having difficulty falling asleep, staying asleep, or having disruptions of sleep? What are some therapies that we could recommend?
Relaxation techniques or
Music.
meditation.
Meditation. Y'all ready? Y'all ready to chat? So the patient asks you, like, give me some, nurse, I can't sleep. What can you recommend? What are you gonna tell them? The
Don't watch TV
relaxation techniques, that's a
before,
great one. I'm sorry, Mary, what you say?
don't watch TV before bed.
Right, so there's a slew of things you need to recommend, and I advise you to know them. Because I don't know if you know them, I don't know if anyone knows them right now. So give me some good sleep hygiene techniques that you're gonna recommend to your patient. We talked about relaxation techniques, powering down before bed.
No lights, no TV or any of that.
Like don't work or do exercise or do homework in bed. Reserve it for sleeping.
Do nothing in bed but sleeping. Yeah, I know what. So yeah, she's gonna recommend some good hygiene. You wanna recommend that they stay on the same routine, like they develop a routine before bed. They can read a book before bed, but don't budget your don't balance your budgets, don't read, don't do like I do, watch endless episodes of Fatal Attraction. I just watch them at night. That puts me to sleep, Fatal Attraction. Then I have nightmares, and it is a vicious cycle I have going on. I teach this, it's my second, third semester, and I still don't do any of these recommendations, not a one. So, and physical exercise, when do you recommend they exercise? Right before bed?
No.
During the day.
No.
Yeah, at least 4 to 6 hours before retiring to bed. And some people may need counseling. You may want to suggest that they don't take naps during the day. Yeah. Okay. And CPAP and BiPAP. So you want to just kind of make sure that they know that they're fitted well and when to wear them only when they're sleeping.
Excuse me, did you say 4 to 6 hours before bed for exercise or 6 to 8 hours?
4 to 6, 6 to 8. You want to do it. You don't want to do it right before. So do it in the daytime. As long as you don't do it before bed. I know a lot of people think that drinking a glass of wine before bed will help you sleep, but it hastens sleep, but you'll soon wake up, but it disrupts your REM. So it's not really a good thing to do before bed. And of course, smoking is nicotine is a stimulant, so you'll have difficulty falling asleep. All right. So nursing process. So tell me some clues that'll alert you to the fact that your patient isn't getting enough sleep. What might you see?
They're tired, obviously.
Yeah, if you're a nurse that work in the daytime, they may be tired, they may be sleeping during the daytime, they may not touch their lunch. And some, adverse effects to not sleeping at night, meaning they may not want to participate in their therapy. So how are they going to get better if they can't participate in their therapies, right? And they may not eat. If they're diabetic, they're not eating. How are we giving them insulin and they're not eating? So lack of sleep affects a lot of their patient care. Yep. So, and what might you see at night to alert you to the fact that your patient isn't sleeping? If you're a night nurse,
They're awake.
simple as that. Nursing man, Nancy nurse, and you're doing your hourly rounds, and this patient was woke at 10, 11, 12, is watching Fatal Attraction probably. Yeah, so that so that might alert you to the fact that they're not sleeping. And so patient interviews, you could just ask them, if they're sleeping during the day, like, are you having trouble sleeping, or why can't you sleep? You might just want to find out what's going on. Right? So we could talk to the doctor, maybe about getting him something in order to help him sleep, some melatonin for shorter periods of time, or we could help them with the winding down process. And you'll also see on some patient doors that they'll have do not take vital signs between the hours of 10 and 6 in the morning. That's so they can sleep. We're tired of y'all bothering them. So yeah. So there's things that we can do and things that we can see. In physical assessment, you might see dark circles around the eyes or puffiness. That are all these physical assessments that perhaps these persons aren't getting enough sleep. And the second little thing piece is your diagnosis, your possible diagnosis related to So once we do the assessment and we gather our diagnosis, now it's planning phase, right? So it's all right there though. So what's the goal for these patients?
To have them sleep normally.
Thank you, Mia. It'd be that simple, Mia, and it'd be right in front of you too. You want them to sleep. You want them to utilize the techniques that you're teaching them. You want them to utilize good sleep hygiene. You want them to you want the patient's spouse to be like, okay, he's snoring less, he's wearing his CPAP and BiPAP properly, and they're having a consistent bedtime. That's what we want to happen. So how do we get that to happen? What do we need to do? How do we get here?
The patient has to practice these things to see, to increase their time to fall asleep or their length of sleep, or they could use the CPAP.
So what I hear you saying is we need to educate, and that's essentially what we're going to do. We're going to educate these patients, right? What else can we do? Educate them about the factors. We're going to make sure. So you have to know the sleep hygiene techniques in order to teach your patients. So that's something you may want to know, right? Okay. So you want to teach, instruct them about the proper use of their devices, teach them about the proper use of medication and potential side effects. So how do we know that our implementation worked? What might we see?
Their sleep improves.
All right. They're sleeping. They're waking up alert and ready to start their day, right? They can participate in their care is what we want them to do, because hospital length of stay shouldn't be that long. So we need to make sure they're getting their therapy, making sure they're getting occupational therapy, making sure they're eating, making sure they're taking their medicine on time. We want to get them better. And if they're sleepy all day, they will not get better. You'll see patients that just don't want to get out of the bed, right? We need to encourage them to do so. And now we know why. They won't get better. It'll be harder for them to fight infections. It'll make their diabetes worse. It all works hand in hand. So sleep is important for those reasons. And how do we know it worked? It's sleeping. Any questions about sleep and sleep deprivation? No? It's pretty simple. I would just advise you guys to know about sleep hygiene And of course, therapeutic techniques. And if a patient requests or requires teaching, you need to be able to teach them. It's not good enough to just sit and stare at me. You need to know, you need to teach them about consequences of lack of sleep. What could happen? Increased risk for accidents, lack of tissue and wound healing, repair body processes, because Ms. Lee stated it best. If people know why, they're more likely to comply. So if you can tell patients the consequences of lack of sleep, then maybe they'll try harder, right? But if you don't know, you can't tell them nothing. So we're gonna miss an opportunity to teach, and we're gonna miss an opportunity to help them get better faster. So you have to know these things. Yeah. I'm gonna make my patients ask my students, give me some good ways to help me sleep. See if they can answer. All right, any questions about no? All right, we gotta move on. Yeah, so another thing, so in the hospital, how can we help these patients go to sleep? We can cluster our care, like if we have something to do, try to do it all at one time, so we're not going back and forth and back and forth. So if you have 4 or 5 patients, you have to get medicine, just bring everything you need in the room with you before you go to bed, making sure you have enough blankets, or ask them, do you need more blankets, so you're only going in and out, in and out. Close the doors if possible. Again, the patients don't need to hear about what happened this weekend or what y'all did over the weekend, and limit interruptions. All right, I think that's it with sleep disorders. And we're about to move on to palliative care. So tell me what you guys read and know about palliative care. Let me move my,
It basically makes someone with a chronic disease more comfortable. Not necessarily someone who's dying, just someone who's, chronically ill.
doesn't necessarily have to be dying. Yeah, so it just aims at improving quality of life and treating symptoms that make patients uncomfortable. And it's just like mitigating suffering among the persons with life-threatening illnesses. So what are some illnesses that you see with patients in palliative care?
Cancer.
Cancer, yep. What other illnesses might you see?
Like kidney failure, liver failure,
Yep. Kidney failure,
Parkinson's disease.
Parkinson's, all of those different processes that impede the quality of life of patients, right? They may not be dying, but just think about what their quality of life looks like. People are living longer, guys. People are living longer because of, advances in healthcare with all this good medication. But with that living longer, they're also sicker. And so they do require things like palliative care to mitigate some of that suffering that they may have. So what's the caveat with palliative care? What could happen in palliative care that can't happen with hospice care?
It
Life
happens.
saving.
Yeah, go ahead.
It can end. It's like got a 6-month time span, and then you reassess.
Yeah, so the thing I was looking for is right there, is with palliative care, patients can have curative treatment. Like if they have congestive heart failure, they can take dobutamine at home if they need to. If they have kidney failure, they're still allowed to have dialysis with palliative care. If they have cancer, they're allowed to have chemotherapy. So that's the big difference between the two. Palliative care, they can have all of those things. And so palliative care can transition to hospice care. And on page 188, there's the 8 domains of palliative care there that tells you more about it, but it's aimed at mitigating suffering among persons with life-threatening illnesses. Yeah? Yeah. So how do we do this? How is this carried out? So when you're talking palliative care, hospice care, you're talking about more than one patient. It's the patients plus their family, right? We're offering support for the family. We're making sure that we address their spiritual and physiological needs. And it's a team approach. Like, who's a part of this team?
A nurse, a doctor, the social worker,
The family.
family.
You even have their religious person, like their preacher or chaplain or something.
Yep, that's all part of this team. And so what we want to stress to patients in palliative care, so you want to, they may not be dying, but they have life-threatening illnesses that probably going to transition to this hospice care. So you want to make sure that they view death as a normal process. And with that being said, you have to let them know signs and symptoms of impending death. You have to just prepare them for, for what's going to happen. And we have to make sure that we are addressing all of their needs, affirming life and relieving pain. That's their main concern in these end of life situations, is pain. And what other distressing symptoms may you see?
Anxiety.
Anxiety,
Depression.
Depression.
depression, shortness of breath. So yes, so we are there to provide support for both the family and the patients, and that's the main thing. So you have to go back into your little bag of tricks and don't forget your therapeutic communication. So that's going to play a lot in this care realm of palliative and hospice care and end of life care. So hospice, is hospice considered palliative care?
Different.
So it is. So hospice is palliative care because it's, it provides for comfort. So it is. It's a bridge of palliative care. The palliative care definitely is in hospice because they're two different things, But this is a branch of palliative care. And this is an interdisciplinary approach as well. So we got those same persons, social work, doctors, nurses, priests, therapists, all those team people are on this, and you want to provide for the holistic needs of your patient. So tell me more about hospice care. What do you know about that?
Now that's when they're definitely like getting ready to pass away, right? Like it's not where they can receive treatment to get better like palliative, but it's definitely working on in the life planning. So isn't it normally like 3 to 6 months before they pass away that they end up in hospice?
That's the prognosis. So can they stay on it past 6 months? Like, what if they're still alive at month 7? What happens to their hospice care?
They have to reassess it.
Yes, and as long as they're showing a need, like they're not getting better, then they could just stay on hospice for as long as, but eventually they're going to pass. But, sometimes my grandma took 3 years and she still, she said she wasn't going nowhere and she meant every word of it. But yeah, so they just reassess. And if the patient looks like they're stabilizing, not getting better, not getting worse, then they'll have to be discharged from hospice. But otherwise, they can stay on it until they don't need it anymore. Either they pass away or they stabilize. And with this, patients receive comfort care only. So what does that look like? What is the comfort care that the patients receive?
Pain management.
Yeah.
Pain medication. That's the main one. That's a big one. They may receive medicine for anxiety.
And like hygiene.
Can't forget those basics. Yes, because we don't want to cause any problems. We want to make sure we're turning these patients. We want to make sure that we're lotioning them, we're putting barrier cream, we're keeping them dry. And hospice care also provides bereavement services to families up to 1 year after the person passes. So essentially, death is the final outcome in hospice care. that's the expectation, and that's what they think is gonna happen. That's the prognosis that's given, and the patient no longer receiving curative treatment. Can they change their mind?
Yeah.
Yes,
So where's most hospice care provided?
In the home.
at home.
In the home. People prefer to die at home, but it can be given in nursing homes. It could be hospitals. It could be a number of places, but most people are at home. Yep. Any questions about hospice or palliative care, about the differences? Yeah, no, okay. So we're going to move on to end of life. And it refers to the final weeks just before death, and signs and symptoms can be present up to 3 months before a patient dies. And so what are some end of life manifestations that you may see?
Not hungry, they won't eat.
Anorexia, yeah. Yeah.
Difficulty breathing.
So difficulty breathing piece is more when death is approaching. Right?
They may be seeing people and communicating with people that have deceased that other people can't see.
Yeah.
They sleep a lot.
Hmm?
Decrease blood pressure.
So yeah, so they may have dyspnea, and they may also have hypotension, anorexia, like y'all talked about, dehydration, altered levels of consciousness, pain, and decreased body temperature. All of those things you may see. And you want to be able to, you need to know this because you need to be able to tell this to the patients and to the family so they won't be caught off guard. So, you know, so when they're like, my mother doesn't want to eat, you can explain to them that that happens at the end of life. Don't worry, they're not starving. They just don't have the drive to eat, you know, so you can let them know. So that is end of life manifestations, but then there's physiological signs of approaching death. Like death is upon us. What you might see then?
Sean Stokes or
Yeah. So the final weeks, you might start seeing different changes besides those manifestations. You might see people know when death is approaching because the patient may have cool extremities, right? Increased sleep, fluid and food intake decreases. They may have incontinence. You'll hear that gurgling and congestion. That's because they can't clear the mucus. They can't cough. They can't get it out. So there's a whole lot of saliva just building up in their mouth, and they call it the death rattle, some people. And this is where you'll get your disorientation, your restlessness, and your change in breathing patterns when death is approaching. Yeah.
I have a quick question. So I've heard of people that it's like a common phenomenon that right before you get to like imminent death, like that patients will like rally and they'll have like a couple of days where they're like doing really good and then they just tank and like doctors like inform the family that like, hey, like I know that we look really good right now, but this like can happen right before we like go past the point of like where we know we're gonna die soon.
That's interesting. I haven't heard that.
That happened to my grandmother recently.
Really?
She had end-stage Parkinson's disease, and she wasn't doing good at all. So she was in and out the hospital. And then the last time she was in the hospital, they sent her home because she started doing better. She wasn't eating or anything. And then when she came back, she was eating like big meals. And then she died in her sleep like 2 days later.
Oh, wow.
That happened like a week ago.
Was she on hospital? Sorry about your loss.
Thank you. No, she wasn't on hospice.
She was not on hospice.
No.
So I think just there are some things that definitely are going to happen physiologically, such as the things we talked about, but I think everything is just different. I worked with a nurse, and 2 weeks before she was down, we were out having dinner. She seemed fine. She said the doctor said her labs were great. But then a week later, she went to the hospital and she just never moved. All these signs that they're talking about, that's what happened. She didn't want to eat, and she loved to eat because we both like Popeyes, and we bonded over food and Popeyes. And it's like she wasn't looking at us. She just wasn't breathing right. So all of these disoriented, she was restless, and she just died. So I think it might just look different, for everyone, but some things are just going to happen. But that's an interesting phenomenon. They get better. But so one of our jobs as nurses is to make sure that we're able to explain what signs and symptoms are going to look like to the family and friends, so they don't, start changing their mind about hospice and want everything done. Because again, if they understand why, they will comply. Because some families, they'll get to the end and they'll get scared or they'll feel guilt, and then they'll be like, no, just intubate my mom, or just, so making sure that we're able to explain death and dying to them is important, and it's part of your job, right? Anybody else has any experience with hospice or hospice care in relation to their family members or worked hospice and want to share? I know the last class, they had good experiences with hospice. They all said the same thing, that the nurses were wonderful and they knew that the patients were going to die. And when my auntie was on hospice, my mother's a hospice social worker, she used to be, and she set hospice up for my auntie before she died. And my cousin, after my aunt passed, she said she was very appreciative of the care that my mother and her company offered, and that she was, she felt calm because she knew what was going to happen. So it was good feedback to have, that she appreciated. And she said, everything your mama said was going to happen, happened. Because these physiological signs just really aren't going to change much. That's how you know death is really upon you. Like end of life, they may be end of life, them signs and symptoms for a while, but when death is upon you, you'll start getting those cool extremities, that disorientation, that gurgling, and those changes in breathing patterns. So with hospice care, what medication are we giving the patients?
Opiates.
Morphine.
Yeah, mainly morphine.
Morphine.
Giving them morphine. And so so I just read an article, so we're not giving it PRN, right? As needed, because that insinuates that the patient can ask you for pain medicine. What if they can't ask you for pain medicine, but they really need it? So you have to be evaluating your patients. And the thing now is you have to offer it, but they can refuse, but offer it to them as ordered. Like if it's ordered every 3 hours, offer it to them every 3 hours, and they have the right to refuse, but at least you're offering, and they don't have to, you're not relying on them asking. But sometimes they just don't want to talk, and they could be suffering. You have to watch those cues, those pain cues, grimacing, or And they may get lorazepam for
Anxiety.
anxiety or shortness of breath. If they look like they're having shortness of breath, sometimes they'll give them Ativan to kind of calm them down and slow those respirations. So we just talked about the end of life manifestations. So psychosocial needs. It's the same thing over and over. We have to be there for the family. We have to provide emotional support. We have to make sure that the arrangements are made. But if these patients are in hospice care, I'm quite sure there's a checklist and all of these things are happening, They're probably all happening. We know that they're DNR. We know who's their funeral service, the funeral home. So all of these things are already in the works. So if a patient's family member is concerned that they're not eating, like how do we talk to them? What do we say to them? They're like, oh, my mama not eating. I think she's starving.
Tell them that it's a normal sign for this time.
She's not starving. And you could just tell him to let her know that there's food available. Even if they're not talking to you, we should still be talking to the patients as if they're there, right? Not talking around them, not talking over them, but kind of talk to them. Ms. Jones, I'm here for you. And, I'm going to lotion your back and let them know what you're doing for them, to still involve them because you don't know what they can hear. They're saying what hearing is the last sense to leave. Let's just assume that's correct, excuse me, and talk to the patients and involve them in their care, even if they're not talking back, but they seem like they're not conscious as to what's going on. So we're gonna talk about our beliefs about death and dying, because with all things culturally or even death and dying, we have to know how we feel about it so we can know how we would handle these situations. And I like to tell my story about my 3 different, populations that I've worked with and my ideas of death and dying and how they kind of evolved over time. So when I was a little young nurse as an LPN worked in a nursing home, when people died, it was like, okay, they're old. That's what happens. So I was fine with that. Then I worked at the ER, the trauma center, and then young people came in with a knife and gun show and they were dying. And I'm like, oh, well, that's on them, live by the sword, die by the sword. And then I started working in the pediatric emergency room. And so, yes, my beliefs about death and dying changed yet again, because there's nothing like seeing a mother, grieve a child that died. So then those deaths hit me way harder than any other population that I've dealt with. So yeah, so how do you guys think that you're gonna feel about working with death? Because any area you work in, you're gonna experience it. You're gonna be working med surg, ICU, ER, peds. You're gonna deal with a dying patient. So you need to evaluate your feelings about it now. So when it happens, you won't be the nurse that's crying and screaming, and then you need to be comforted because they're just not professional, and that's not what we're going to do. So what do y'all think y'all feel about death and dying? Or working with patients that are dying?
I think a lot of times death and dying is, so I work in veterinary medicine and my grandfather had ALS.
Okay.
And he chose to not do a tracheostomy or anything. And I kind of wish that we had humane euthanasia, because losing your ability to move anything, but also being completely cognitively aware of what's going on. I can't, that's the least thing I would ever want to experience in my life. And I was even though I was sad when he died, I was relieved and very grateful, because it's it was just suffering. It was just horrific suffering. So
you guys didn't have hospice care or palliative care to mitigate some of that suffering? That's what it's there for.
he was on morphine, but I mean, there's only so much
Yeah.
But I don't know. I just think that death is sometimes a gift.
Yeah, that's one way to look at it. Especially when nothing's working. Like you said, the morphine, only so much morphine and Ativan can do when there's really nothing else to do, right? Anybody else want to share how they think they feel about death and dying and caring for patients?
I agree with Bianca. Like she said, sometimes it is a gift. I lost my mom, and she was somebody who was very vibrant, active, always at work, enjoyed a full life. And then all of a sudden, her heart started going out on her. She got diagnosed with congestive heart failure and things. And you sat there and you watch her quality of life decline. And it's you see the anxiety come on her. You see, she can't go where she want to go, do what she want to do. She have to give up her job. She was a chef, things like that. So, when she finally passed away, it was sudden. It was not, even though you knew, something was wrong, it was very sudden. And, even with that, you still don't, you know, like, I mean, I was heartbroken, don't get me wrong, but then I feel like Bianca, like sometimes it's a gift for them because she wasn't happy. She wasn't enjoying her life. So going through that, I definitely look at that like it is a part of life, like whether it's a blessing to someone or a gift or not. I just want to make sure I'm doing the best to help them die with dignity. You know what I mean?
Yes,
Like not to take
absolutely.
anything away from them with that. So, because that was a big part of getting into nursing. I wasn't too sure if I can handle that, you
Yeah.
know, dealing with dying patients all the time. But when I think about it more and more, I hope I'm not the nurse in the corner crying, but I do want to believe that I can not make it about me and make sure it's about them and give them the best death, you know, that they can have, like give them death with dignity.
Yes, very good. Was your mother on palliative care or hospice?
No, she like we didn't know about those things at that time, and you know, no health insurance, you know, things like that. So basically she was just taking her medication and then she had a heart attack. Like, and of course I'm pretty sure I was younger. She probably wasn't taking it accordingly. I think that's what sort of propelled me into being like an advocate like in that manner now, because it's like ain't no way in hell she would have got away with that nowadays. But you know, back in the day when I was younger, you know, I'm pretty sure, you know, she wasn't doing the right things and not being led to the right avenues to get appropriate help neither.
Yeah. Sorry for your loss. I know it was a while ago, but I know it's still, you know, the mother,
Thank you.
of course.
I believe I work with peds. So to see those parents lose their children at such a young age, I just believe that that's probably one of the hardest things that you have to do. But I see a lot of nurses, some of them are still breaking down crying, and some of them you can just, you know, obviously see that they're sad, but it just takes a special type of heart to work with peds.
I agree.
Rather, yeah.
That's how I felt about the PDR. It was a sad thing, but you know, we're jumping ahead. But guys, you cannot. The patient's family should not be comforting you. Like if you feel sad like that, you need to go into a room. You need to take a moment. You need to do something. We have to be strong and we have to be their advocates. We can't. I know sometimes you get close to these patients. I know sometimes it catches you off guard, but you have to remain professional. I had a student in another class. She said how she broke down crying, and after it was all over, she had to have a talking to by her supervisors and stuff. Like you just can't. You have to get a grip. You can't lose control like that. We're there for them. They should not be there for us.
I work in the NICU, and I saw my first deceased baby, and it was like kind of different. Because the mom, she actually did like keep the baby overnight, even though the baby had died like 12 hours ago.
Mhm.
She like, you know, kept the baby. We allowed her to, you know, grieve as long as she needed. And like, you know, when she was ready to, you know, let go, we were able to like take over. But
Mhm.
it was different because, you know, I can't ever imagine, you know, you're about to have a baby that you've been carrying for several weeks. You know, I think the baby was late 20 weeks. So very premature, but yeah, it was sad, but it was different.
Them labor and delivery nurses see it all the time, and I guarantee you're not gonna see them break it down because you have to just come to grips with this is a part of life. This is a part of the area I work in, and this is gonna happen. You could feel bad for them because, of course, I have a 7-year-old, so when I see little kids dying, it hurts. I hurt for the family, but you gotta stay professional and you gotta keep it together. Yep. So how can we support the loved ones? Just being there for them. Nothing more than anything. We need to listen. We shouldn't do a lot of talking. Just do a whole lot of listening. Just let them know that we're here for you if you need me, and just keep it short and sweet. Keep it simple. Yep. We'll do one more slide, then we'll take a break. So, page 185, there's a dying person's Bill of Rights. And just a couple of those rights that I like to point out to you guys. Read through them because, of course, everything's important. But one is that they deserve honesty. If they ask, am I about to die? We have to tell them, you know, you have to find, you know, therapeutic ways to tell them, you know, death is common, death is, you know, maybe upon you because you are ill, but we're here for you. You won't be alone. So always like make them feel better about it. Tell them the truth and sandwich it with, you know, we're here for you, with a comforting statement. But we owe them the right to honesty. And they also, another one I like to pull out is they have the right not to die alone. Like they shouldn't die alone. If their family isn't there, then we need to be there for them in whatever capacity is needed. If we have to sit there till the family comes, if you need to hold their hand till the family comes, or if you're not comfortable with it, get somebody else to go in there and do it, but they have the right not to die alone. So what is that, like what happens? How do we know that a patient is, I want to see, dead, or a patient has passed away? How do we know that happens?
Their heart stops, their, you know, their oxygen, I mean, they're not getting any oxygen or circulation.
All the essential functions stop. They're not breathing, irreversible brain function, and cessation of heartbeat. All of those things stop. That's how we know that the patient is deceased. And then there's good death. So when we're talking to our patients and we're in a family and we're teaching them about signs and symptoms of approaching death, when we're teaching them about signs and symptoms of end of life, we need to also ask what's their wishes and desires for their family. Like, what do they think a good death looks like? So we always want to have their input. Like, what does that look like to you? So you want to find out from your patient. It's a good death is just what it says. You want the patient free of avoidable distress. And a bad death is the exact opposite, experiencing prolonged, untreated, unnecessary pain and suffering. Nobody would want a bad death, you know, if you have to choose, who's going to choose that? So we're going to focus on providing good deaths. Any questions so far about hospice? We know about the medication. We know that now it's like we have to offer the medication. It's no longer just about PRN, because this is the most up-to-date information I was reading on UpToDate. It's offered but refused. So because the patient may not be able to ask you, or they may just be so out of it that they don't want to ask, they're just too tired to talk. But we need to offer them the medicine, and they do have the right to refuse. So it's not longer PRN. So what if they never ask? That's a new thing.
If you offer and they can't really communicate, or that they can't say yes, you would just give it unless they
Yeah, so if you feel like they're in pain and you can look at them and you can see these cues, the grimaces, the tachycardia, whatever you see, and if you think they're in pain and they need it, then you can give it to them. Yep. So palliative care, you could have curative treatment along with that. Hospice care, you cannot. As long as the patient is not getting better, they can stay on hospice care until death. And the main thing that the patients worry about when they're dying is pain. So you want to make sure we're treating pain, treating restlessness. That's one of the most important things that we could treat, is keeping them out of pain. And don't forget those basic comfort measures, the turning them, because we don't want to cause more issues by not turning them. So we're making sure that we're repositioning patients, we're lotioning, we're giving massages, we're talking to them, you know. So let's not forget all those things that go along with providing comforts. We don't want to cause any unnecessary discomforts. Okay, you guys could take 10 minutes and we'll wrap it up. All right, so end of life cultural considerations. Again, we must honor and respect all persons' culture and religious beliefs and traditions, and they're important at the end of life. Also, if you have a non-English speaking patient, we need to make sure that we are providing interpreter services for those patients. We can't say they speak a little English or a little that. We need to make sure that they are afforded the same information as our English speaking patients. So make sure you're using interpreter services. And I feel like that for all patients, not just end of life, just in general, making sure that we are providing those services for our patients that need them. And expressions of grief may be culturally influenced. Some cultures, people cry loudly and very expressive. In other cultures, they may not show grief outwardly. So we can't be judgmental in either scenario, right? Just because someone's not crying doesn't mean that they're not sad or they're not grieving. So we need to reserve our judgments and just be there for the patients. So we're gonna talk a little about legal and ethical issues associated with death and dying. So before a patient gets to the point where they can't communicate, we need to make sure we're getting their advance directives at that time. Before they're sick, before they can't talk, we need to make sure that we know their wishes and desires. Do they wanna not be resuscitated, or do they wanna get CPR and not be intubated? Or do they want to allow natural death? We need to find out their healthcare proxy. We need to know all of these things before they be incapacitated and can't answer these questions for us. But with hospice patients, so you don't have to have a DNR, like it's not mandatory to have a DNR, but most patients on hospice care do not resuscitate. I mean, most of them do not resuscitate. And euthanasia and assisted suicide, someone mentioned euthanasia. I mean, it's just not legal here in Louisiana. It may be legal in other places, but it's not legal here. That's all I'm gonna say about that. Don't participate in it, it's not legal. So let me go back to the, so just to recap the nurse's role in end of life care, we need to make sure that we are meeting the patient's goals and the family's goals. We need to make sure that they know about advance directives and that the documentation is, easily available and accessible. We need to make sure that we're teaching patients and family about procedures and treatment at the end of life, which there's not going to be a whole lot of any of that procedures or treatments at the end of life. Remember, we're not doing any of that. Even going back to hospice care with dyspnea and oxygen. Oxygen is given to patients just as a comfort care, but it doesn't really do anything for patients when they're dying, right? Just like PEG tubes and NG tubes. I think I may have a slide about that, about oxygen and tube feedings. And so we want to make sure we encourage patients to think about their preference for end of life treatment. We just kind of discussed that, and we are the advocates for our patients. In spite of different opinions by healthcare proxy, if the patient wants to change their mind and they want to now be resuscitated, we advocate for them. We let the physician know, or whomever the provider is, that that's what's going on now. So we're just here for them, and whatever they need, we're relaying those desires. And provide palliative care regardless of their status. You can't say, oh, the patient, they do a DNR, we ain't got to do all that. You still have to do everything. You got to mitigate suffering. We have to provide comfort. So it doesn't stop because they're DNR or A&D, which is allowing natural death. And of course, taking care of these patients at the end of life is a collaborative effort by all of those persons that we named initially. And nurses are responsible for communicating changes in a patient's condition. Nurses are responsible for a lot. If you didn't know, now you know. So yeah, pain is your most common end of life symptom, is the thing that the patients worry about the most, and it is probably gonna be the thing that we need to make sure we are taking care of more than anything. Is gonna be that pain. And of course, they can get oxygen for dyspnea. And when you're given oxygen at the end of life, it's basically for comfort measures and reassurance. It does nothing at the end of life, but it just comforts the patient. Stool softeners, a laxative, we're going to give for constipation. If the patient is nauseated, we're going to give them an antiemetic. And sometimes they'll take patients off their medications if they're hospice, but they will give them stuff like Keppra or things for seizures if they have seizures. But other than that, they won't be on a whole lot of medications. Here we go. So non-pharmacologic therapies, feeding tubes. You just won't see them. It's not recommended. It doesn't provide, research says it doesn't help with their strength. It doesn't help with their energy. It just sets them up for aspiration. They already can't control their fluids. They're not breathing properly, and so we're going to give them feeding tubes. You just won't see it. And if you do see it, it's going to be a case-by-case situation where the family is probably insisting upon it. But it's not a hospice treatment. It's just not what, not in the hospice treatment regimen. That's just not what they do. So I put it there because you may see it. And I don't want you to say, Ms. Brown said. You won't see it often, but if a family insists that they want their mama or daddy or whomsoever with a feeding tube, they may do it. They may discharge them for hospice, but they may do it. And CPR must be administered for patients without a DNR. Again, in the hospital, this becomes important. If they don't have DNRs and they could be sick and you could assume they're dying. But if they don't have a DNR in place, you have to do CPR. Hospice, I think they get all of this out the way ahead of time. This won't even be a question. If you're going on hospice, you know what the expectation is and you know what the end result is. Of course, anybody could change their mind, but if you're in a hospital and the patient does not have a DNR, commence to doing CPR. We're doing the whole works. But hospice, it'll be different. Mechanical ventilation, you won't see it with hospice patients. That's just not the goal of care. That's not the goal of treatment, and it's not the function of hospice. But we can give them gentle touch, music therapy, a little massage therapy, and animal assisted therapy. The last group told me they've seen this animal assisted therapy with chemo patients. Has anyone seen this in a hospital? Animals allowed to come in? Huh?
I have. They come to Children's.
Oh, do they?
Yep.
I'm pretty sure that the patients appreciate it. I haven't seen it, but yeah, they were saying it happens. So the nursing process, so we're assessing their pain level, we're assessing their awareness of dying, finding out what they know about it, what they think about it, so we can kind of, provide them with that psychosocial support and assess the signs of approaching death. And y'all remember what those signs are? Cool extremities, increased sleeping, change in breathing pattern, congestion or gurgling. All of those are some hints or signs and symptoms that death is approaching. So you got to make sure that the patients and their family understand that, and you guys need to understand it as well. And inquiring about their living wills, the healthcare proxy, and their status, and assessing physical, emotional, and spiritual needs. Ongoing assessment, changing the care plan as needed. Same stuff. And these are some diagnoses that you may, based on the problems that the patient may have, you may see these diagnoses. Impaired swallowing. So planning. So these are our goals. So how do we get to these goals? What care will we be implementing to reach these goals? Yeah.
So to reach those goals, we're going to make sure that they have their pain medication. The family knows what in the life look like.
Who's talking?
Stephanie.
Thank you, Miss Stephanie. It's
Okay.
simple as that. We've gone over all of these things that we need to do for the patient. So how do we reach goals? Just what she said, we're giving them pain medication, we're treating constipation, we're keeping them clean and dry, we're repositioning these patients, we're making sure that the family knows the dying process, knows what approaching that looks like. The same stuff. You're just putting it in a nursing process format at this point. All right. And that's your implementation. And how do we know that our implementation worked?
The patient shows that they're not in pain. They, you know,
Yeah,
what the
simple as
patient
that.
looks like.
It's right there. Family members are prepared. They're clear about what's going to happen. They're not changing their mind at the tail end, scrambling to be like, no, intubate. No, we want to make sure they're clear about the process, and we want to make sure that we're doing what we say we're going to do, and that's keep that patient comfortable. We don't want to develop decubiti or tissue injury at the tail end because we're not caring for these patients properly. So we want to do our part, and they're going to do their part, and the patient's going to experience a good death is always the expectation. And from what my experience with hospice is it was a great experience. Other students say the nurses are really good. They knew what they were talking about. They're very competent and very professional. And so performing postmortem care. Again, I'll just stick to hospice. So postmortem care, you're gonna make sure, because the family may call the nurse first. If they experience a death, they may call the nurse first. The nurse will have to go out and, pronounce them or call the physician to say, yes, this patient is in fact deceased. And you may just want to clean the patient up if they have, like sometimes they'll have like an incontinent episode and they'll, be full of feces. So other family members may start to come. So in this aspect of postmortem care, it's like clean the patient up, change their sheets, change their linen, make sure their mouth is clean because they may have like a mucus come out their mouth and dry. But in the hospital, postmortem care looks a little different. Like if they're in the hospital, they have tubes in, the tubes don't come out. And it's a coroner case. So most hospice patients are not coroner cases because the death is expected. And then you'll just call the funeral home. That's the gist of postmortem care. I didn't talk to y'all about LOPA, organ donation. So I'll tell you this is all you need to know about LOPA in the state of Louisiana and other states. I don't know what you need to know. But if you're working in the hospital, as far as LOPA is concerned, you don't talk to the family about organ donation. You don't approach them about it. You don't mention it to them. You're going to have a point person in your hospital on your unit. You're going to have the ER manager, the house supervisor. They're going to get in touch with the LOPA organization, which is the Louisiana Organ Procurement Agency, LOPA. And then LOPA, somebody from LOPA will come to the hospital and discuss organ donations with the family. I'll tell you that right now in the hospital, do not discuss it with family members. Don't say, oh, you ever thought about organ donation? That is not your job. Don't do it. That's all you need to know about LOPA. And as far as LOPA in the hospice, like I say, hospice is kind of set up a certain way and is set up for patients that are dying at the end of life. So I think all of these things are going to be dealt with in the beginning. And I don't even think they'll be, because to be eligible for LOPA, they have to have oxygen going, they have to have fluid going. So I don't think hospice patients are really going to be candidates for organ donations. Because it's a whole process. When we worked in the ER, we had to keep them on a ventilator. Even if they were dead, we had to make sure they still had fluids going. Like there are certain things you have to do to preserve those organs, so they could be, what do I want to say? Transplanted. You have to make sure they're still functioning even though the patient's dead. So with hospice, those things just don't happen. That's what you need to know about those. So we're gonna do a little review. And then that's gonna be it. So a patient's husband states she doesn't want to eat. I think she's given up. How should a nurse respond?
It's a normal part of the process. You can still offer the food.
That's a big thing. Make sure you say, just let her know that food's available if you want it. So if this patient's diabetic, should we be giving her Kate?
I mean, at this point, it's probably okay, right?
At this point, it's probably okay.
If it makes them eat.
If it makes them happy and if they're comfortable, then yes, we'll just offer them whatever they can eat. Sometimes they just want soft food because they can't really chew or they don't have the energy to do so. Or if the patient will have cirrhosis, but they like to have them a little shot of vodka in the morning. What are we doing?
Whatever they want.
We're giving them whatever they want at this point. Ain't no sense in trying to stop nothing now. So yeah, you want a joint, whatever they want. I don't know. But yeah, at this point, it doesn't really matter. The thing is comfort and letting them have a decent quality of life, to the extent that they can. So at this point, it doesn't really matter. Yeah. All right, yeah, but that's what you'll tell them. She's not starving. I wouldn't worry about that, but let her know that there's food available if and when she desires it. All right, so a patient reports that she has a hard time falling asleep and asks the nurse for methods that will help induce sleep. What are some things we can tell them that'll help her induce sleep?
You could recommend exercise, 4 to 6 hours before bedtime. Encourage them to generally just start winding down and try to keep a sleep schedule, have a regular time for sleep.
Let them know
Like-
that they shouldn't take naps during the day.
Relaxation techniques, low light, low noise.
Read a book. So all of those things, you want to know those relaxation techniques. Yep. Sleep pattern, regular sleep schedule, moderate exercise in the morning. All of those things are probably good things for you to teach your patient. All right, so, oh wait, I can launch a poll for y'all. So I'm about to give y'all a poll and we'll take about 5 minutes. It's only 3 questions and then we'll go over them. Can you guys see it? Yeah, okay.
Yeah.
Good. And the first one is select all that apply. And the other 2 are just multiple choice. All right, two more people and then we'll wrap it up. All right, I'm going to end the poll. Only 4 people didn't complete it. That's fine. We're going to share results, and can someone read one and tell me what answers they chose and tell me, yeah, we'll just discuss it.
Hospice care is not appropriate in which of the following circumstances? I chose number 3. The patient is undergoing experimental chemotherapy.
So why is choice 1 and choice 4 not correct?
Choice 1, they're choosing not to get curative treatment. And 4, it's palliative chemotherapy is it's just keeping them comfortable. It's not trying to cure the disease.
Yeah, so you had 3 right answers and 1 wrong answer, right? The requirements for hospice care is that you forego curative treatment. Remember, hospice care, you cannot have curative treatment. You can't be on dialysis. You can't be on the vitamin drips. You can't be on getting chemotherapy. So that answer is correct. And the patient's prognosis, you all got that one right. That's correct, 3 to 6 months. And the patient receiving palliative chemotherapy, that's correct as well. So they're not using it as a curative thing, they're just using it palliatively. And so the patient undergoing experimental chemotherapy look like they're still looking for a cure. So that's curative treatment, and that just doesn't work with hospice care. It'll work with palliative care, but not hospice care. Thank you, Roxy. All right, number 2. This is the select all that applies. Y'all want to go over it?
Ms. Jones is receiving hospice care in the nursing home. During the assessment, the nurse observed the patient is unconscious, has a wet, noisy respirations, and cool, mottled extremities. The nurse understands which of these actions are indicated. So the 2 that I picked were notifying the family and notifying the provider. I didn't go with anticholinergic because that's going to treat. We're not trying to treat. They're like an end stage, like they're at like the end. I didn't know about sternal rub because that would assess if they're like more conscious. And then I didn't pick full system assessment because I don't need to worry about bowel sounds or anything like that's. I don't need to assess the whole patient. So the one that I didn't know would be sternal rub, but I didn't pick it.
Yeah, I'm glad you didn't pick it because sternal rub's hurt and the patient's unconscious. That's okay because what are those signs, those cues in the paragraph telling you? Like what is
like imminent death, like
imminent
actively
death.
dying.
And so they did pick C. The book, like they do say, provide an anticholinergic. They're already dying, but do we want them choking as well? And that's the only reason why, just to dry up those secretions. It's not really curing. It's again still providing comfort. Because if the patient was to wake up, you know, we don't want them choking because we just didn't do anything about it. So yes, notifying the patient's family because again, those are signs and symptoms of impending death. Notify the provider, again, signs and symptoms of impending death. But they also said that request an order for anticholinergic. And my only guess is, what if the patient wakes up on their own? Who knows? We don't want them choking on their secretions. We could, you know, alleviate that with an anticholinergic, like a little patch that goes behind the head.
So it's because I read it at like anticholinergic as in like to increase heart rate and like, because you know, we use like atropine in a code.
No, you see how they say she has wet, noisy respirations? They just kind of just to decrease some of those secretions, so they just won't be drowning in their own secretions. They're dying anyway. I can see why you picked the two, but it's all three.
Cool.
Thank you, Miss Bianca. All right, the last one. Y'all had enough?
Can I ask with that question?
Sure.
It seems like it's expected the patient's dying and they're on hospice in a nursing home. I didn't pick provide the provider because it seems like, you know, this patient's dying. That's the expected thing. Like when you, I mean, I figured you would just wait until they've expired.
I think it's just preparing a doctor just in case he's asleep or needs to wake up, you know, because they have to pronounce them. I read somewhere that nurses can pronounce them sometimes, but I think it's just giving the doctors a heads up. But you can call them, you can call doctor anytime. It is expected, but when it happens, we still need to let them know.
All right, thank you.
So why we calling the family? Just to kind of give them a heads up that this is what it's looking like. Number 3.
Mr. Smith's wife is in the terminal stage of COPD. He is anxious that his wife is uncomfortable during her last hours. Nurse finds him tearful. Which communication should be used? I can see that you're upset, Mr. Smith. Would you like to talk about it?
That's absolutely correct. So why isn't choice 3 correct?
Because it's like, I guess it's like non-therapeutic. Like
Yeah,
it's,
because you're not addressing his concerns. You're just like, is your family here? So the man's crying and we gotta access his family. So what if he says no? So yeah, it's kind of dismissive. Like, I'm not here for you, but let me find somebody to come deal with you right quick because I can't. Is your family here? So yeah.
was this one a select all that apply? Because they let us
It
pick
was
multiple.
not.
Oh, because I also picked choice 4. Do you think your wife would like a visit for pastoral care? I picked both 2 and 4.
So I think this question was more about him, more so than his wife. So we need to deal with him. So remember, we have 2 patients, or we may have 10 patients. It could be the patient plus their adult children, plus their husband, but you know, so I think at this moment, this was mainly about him. Right? And that is it. Any questions, any looming questions about hospice? But I think the main thing that you just need to know that the goal of hospice is to provide comfort care, and we provide that care by treating symptoms. If they're in pain, we give them pain medicine. If they're constipated, we give them laxatives, so on and so forth, right? But the main thing is providing comfort and pain relief.
I have a quick question that is,
Yeah.
I don't know if it's got like a flat answer or not, but like, so for DNR patients, we don't, if they're not officially expressly DNR, we do CPR. What if you're in a situation where, let's say you're in the ER and a patient comes in by an ambulance and a family member is telling you, my dad is a DNR, don't do CPR. Do you take at face value what the family member says, or do you just do CPR because you have to have it like documentation?
That's what I said in the last group. There's this thing called LA Post, and I think that they have like these statuses in the LA Post that paramedics can pull up. But if they don't have the documentation, we are doing CPR, period. Because don't do it and watch what happens. You'll never find that sheet of paper. And then the hospital do CPR. If they can't produce it, and I need to look up that LA Post more, but we have to do it. It doesn't matter what the family says if they can't produce it.